comparison, and they did exclude patients with severe anaphylaxis, it did have its advantages in the promising treatment that it shows. And even more interestingly, the study does plan to continue and see what is the long-term tolerance provided by this treatment in these patients. So I think it'll be interesting to see what the results of that study will be in the future. So now we'll move on to the second type of treatment. Now that we've seen how the potential for OIT, let's look at what anti-IgE immunotherapy, a different form of treatment. Pictured here is an IgE molecule. This is the light chain, this is the light chain, and here we have a heavy chain and a heavy chain. This is a variable region composed of part of the heavy chain and part of the light chain, and this bottom portion is the constant region. The third constant domain of the heavy chain is called the C-epsilon-3 domain, and it serves as the binding site for the mast cell receptor Fc-epsilon-R1. So if you remember the very first picture I showed of the mast cell, this is where it would have been connected to the Fc-epsilon-R1. Anti-IgE is an IgG that can be manufactured with this C-epsilon-3 domain as its epitope. So anti-IgE will bind IgE and prevent it from binding to the Fc-epsilon-R1 receptor on mast cells, basophils, and eosinophils. Pictured here, we have anti-IgE. Omalizumab is the one drug that I mentioned earlier, but we can see how anti-IgE binds to IgE and prevents it from binding and eliciting the allergic response. The degranulation of the cells can no longer occur because they're not bound to proceed that signal pathway. And then also in a positive feedback manner, the receptor production is actually reduced when the binding is reduced. Interesting thing to note about anti-IgE is it binds to IgE regardless of allergen specificity, because it's only binding to the constant region and the allergen specificity is in the variable region, so it can be used for any type of IgE-mediated allergic reactions. And these immune complexes here of IgE, anti-IgE, and potentially allergen, if it's bound, are eliminated by urinary excretion with no harm to the patient. So Leung and his colleagues tested this also in a double-blind placebo-controlled study. They tested anti-IgE for peanut allergies. They hypothesized that TNX-901, which is a humanized IgG1 monoclonal anti-IgE, will increase peanut tolerance in peanut allergic individuals. 82 subjects completed the trial. They were between the ages of 12 and 60, and they had a history of peanut allergies with serum IgE between 30 and 1,000 IU per milliliter. In this case, they did conduct an oral food challenge at the start of the study to determine how much each patient could tolerate before receiving any treatment. 4 experimental groups were randomly assigned. So 23 were assigned to the placebo group, 19 received 150 milligrams, 19 received 300 milligrams, and 21 received 450 milligrams of the TNX-901, which is the anti-IgE. Doses of the drug were administered subcutaneously in a masked syringe, of course, to maintain the double-blind aspect of the study. TNX-901 was administered every 4 weeks, 4 doses total over the course of 12 weeks. So they started at the beginning with 1 dose. And evaluations, including blood tests and urine samples, were performed every 4 weeks when the subjects returned for their dose. A final oral food challenge was completed 2 to 4 weeks after the last dose, so this is 14 to 16 weeks after the start of the study. And a final evaluation was completed 8 weeks after the final dose, so 20 weeks after the start of the study. Serum, total IgE, free IgE, and peanut-specific IgE were measured. So here are the results of the oral food challenges. The light blue, so this represents threshold of peanut that was tolerated. Light blue represents at screening, so initial oral food challenge here. And dark blue represents final oral food challenge. And you can see all 4 groups are represented on this graph. Mean increase in threshold sensitivity reached significance only in the 450 milligram group. This p-value was less than 0.001. In this group over here, we saw that tolerance increased from 178 milligrams, so approximately half a peanut, to 2,805 milligrams, so approximately 8 to 9 peanuts. This was the only one that showed a significant change. However, the results for trend with increasing dose were also significant, so if we only observe the dark blue bars, we can see that overall, the higher the dose, the higher the tolerance. and this p-value was less than 0.001. Here are the results for serum IgE levels. The placebo group, from mean baseline to final, actually had a slight increase in IgE levels. 150 milligram group had an 88% decrease. 300 milligram group an 89.3% decrease. And in the 450 milligram group, we observed a 93.2% decrease in IgE levels. And they tested again after 8 weeks, and the IgE levels remain decreased 8 weeks after receiving treatment. Although they're not quite as decreased as they were, they're still decreased. Overall, this study confirmed the role of IgE in peanut allergies, so we were able to observe that patients with lower serum IgE had a higher tolerance to peanuts. Furthermore, it demonstrated that anti-IgE at a high enough dose could increase tolerance to peanuts. Here we saw patients being able to ingest 8 to 9 peanuts at the end of the study, so while this is not complete tolerance, it could at least protect against accidental ingestions. The long-term tolerance of this treatment must be established, so is this something that patients are going to have to be on for life, or that they can receive for a period of time and eliminate their allergy? Unfortunately, TNX-901, specifically that was used in this study, is not commercially available, but I did mention Zoller at the beginning, which uses the same mechanism, and we can learn from the anti-IgE mechanism of this study in the effectiveness of this treatment for peanut allergies. So overall, we were able to observe that both OIT and anti-IgE are potentially effective preventative treatments for peanut allergies. While neither of them were able to provide complete tolerance in the studies that we looked at, they are promising for at least protecting against accidental ingestion. And future studies can focus on, do we need to increase the dose, do we need to give the treatment over a longer period of time to provide an even higher tolerance to peanuts to these patients. So, yeah, that's what I just said. And so I'm interested in seeing what a combination of these treatments would look like. It has been tested in milk allergy and proven to be effective, but the idea behind it is that anti-IgE would lower the risk of side effects of OIT. Because OIT is actually administering the allergen, if we give anti-IgE at the same time, potentially we could see less side effects to actually giving the allergen. We also must determine the safety and effectiveness for all patients. So in the first study I mentioned, they excluded patients with anaphylaxis. Well, unfortunately, these patients are going to be the ones seeking treatment first because they have the most serious conditions. So we must determine which of these treatments are safe for them and how effective are they in preventing the anaphylaxis. And finally, we must determine the long-term tolerance provided by these treatments. I mentioned that one study that was planning to continue and determine the long-term tolerance, but I think it would be helpful to determine the second study and see how long is this tolerance that's going to be provided. Do you have any questions for me?
I just have questions for Rose.
Yeah.
So when they were testing this, did they just have like EpiPens on standby for everyone? Or?
Yeah, it was in a very controlled environment, so in like a medical office with lots of doctors there. Yes.
What about when you took it to home and you were taking the doses on your own? Was there, do you know of any?
Yeah, I think they had like someone on call all the time for them available. So yeah, it was over the course of a year. So yeah, they did. Yeah.
Do you know how much in your antibody study, I forget the name of the anti-IgE thing, but it only went up to 400 milligrams or 450 milligrams. But it seems like if you went higher, it would do better. And I was just wondering if there's anything about how much is used in asthma or eczema or anything else. I guess you said it was used for asthma.
It's used for asthma. I don't think what I read. I think the dose that they give for asthma is closer to 300 milligrams.
Okay.
So I don't know if they know if it's safe to give more.
Yeah.
So.
Like, you know, I want to see, let's try 900.
Yeah.
But that's a lot.
Yeah.
That's almost a grand. But.
So you think you could probably even lower the dose from what we're saying is already a low dose if you combine the therapies?
Yeah, I think that'd be interesting to see.
Any other questions? Yes,
Yeah.
more.
Does second test allow patients who had a history of anaphylaxis?
I don't think so. They didn't specifically say that in the study, but they listed the symptoms that most of the patients had, and none of them had any severe symptoms. So, yeah. Usually they try to avoid that because the oral food challenge is very risky with patients with anaphylaxis. So.
Guys have any other questions? All right, then let's thank Rose for her seminar.